for joining us. We're here today for our third installment in our, oh, I see something on the screen, Andre, a gray box covering up our little talk, thanks. Of our October 2022 worker-focused science and prevention. I'm so pleased today we're just over the midway mark. We have 2 more weeks coming to you at the same time, same station, Thursdays from 1 to 3. And today we're going to speak about occupational exposures and community responses. And we've really been trying to focus on the worker's voice throughout the session and really talk about worker informing science and also then the science helping the workers, and really pleased for the session we have today. A few logistic items just to mention. Well, please feel free to place your questions in the chat box, and Jennifer will likely be the one reading them today because I have a little cough. And what else did I want to tell you? I think that was it. We will be providing the slides and video archive on our website by next week, so people can follow up or share with their joint health and safety committees, which is what we like all of this information and knowledge translation to provide at your convenience. So without further ado, I'm going to hand it over to our occupational hygienist, Andre Gavin. So happy to have Andre is the hygienist on the project that we're going to be speaking about first. And over to you, Andre, to introduce our first speaker. Thank you.
Can you hear me?
Hear you now, loud and clear.
Okay, thanks, Kimberly. I'm just gonna ask Amanda to share her presentation while I introduce her. And I'll talk a little bit about the project and kind of how it came about. So we're working with Unifor now to identify cytotoxin in the workplace. So a member of Unifor Mine Mill, representing nurses and personal support workers at long-term care facilities here in Sudbury, contacted Occupational regarding cytotoxins in the workplace. And the more we spoke with the rep, the more we've seen how people working in these facilities were getting affected by these cytotoxic medications. The workplace has implemented some minimal safeguards, but there are some numerous potential historic and current exposures that have come to light. So OCAL is currently working with the union to help gather information for workers' compensation claims and to implement change in the workplace. So our first speaker is Amanda McGaughy. She's a full-time personal support worker in a long-term care facility here in Sudbury. She's been in this role for 13 years, and she's also the co-chair of her Joint Health and Safety Committee and the WSIB rep with her local union, which is Unifor. She's here today to speak to us about cytotoxins in the workplace and to discuss how this can impact those in our community. So Amanda, it's all yours.
And Amanda, you'll just want to push the presentation mode up on your top. Yeah, perfect. Button on the top left. Yep, there you go. Thank you. You may be muted, Amanda.
Hello?
Yep, we hear you now.
Okay, perfect. Sorry, I couldn't figure that out.
Okay.
Hi, my name is Amanda. Like Andre said, thank you very much, Andre, for introducing me. I'm going to start today by just explaining a bit about cytotoxic drug exposure, understanding the hazard, effects, exposures, and prevention. Oh, sorry. Okay, cytotoxic drugs, what are they?
Oh, Amanda, we've lost your slides.
Oh, done here. Maybe I have to share it again. There we go.
You go. And in presentation mode. Perfect.
Okay, perfect.
There you go.
Okay. Okay, cytotoxic drugs, what are they? Cytotoxic drugs are sometimes called antineoplastics, and they're a group of medicines that contain chemicals which are toxic to cells, preventing their replication or their growth. So essentially, cytotoxic means toxic or deadly to cells. Now, cytotoxic drugs are used widely in healthcare settings, as well as in the community in the treatment of cancers, as well as other diseases such as rheumatoid arthritis and multiple sclerosis. Once they enter the body, their actions are not tightly targeted. They can produce side effects both to the patients and others who become exposed. Cytotoxic agents are used in chemotherapy because they can stop or slow the division and spread of cancer cells, which is what we would like. These powerful drugs, however, can also lead to many varying side effects. Both patients and workers who handle cytotoxic drugs are at risk of suffering these side effects. Exposed healthcare workers risk the same side effects as patients, but they get no therapeutic benefit. Exposures to even a very small concentration of certain cytotoxic drugs may be hazardous for workers who handle them or work near them. Like all exposures to toxic agents, the possibility that a worker will experience adverse effects increases with the amount and frequency of exposure combined with the lack of proper work practices. Cytotoxic drugs, they're used in different ways and a wide variety of settings, including hospitals, hospices, care homes, charitable organizations, and domestic homes. They may also be used in veterinary clinics. They can be given through chemotherapy infusions, chemotherapy pills, creams, and directly to the body area or cancer site. Millions of healthcare workers are exposed in Canada and around the world to cytotoxic drugs. Now, what are the exposure risks? The toxicity of cytotoxic drugs makes them potentially dangerous to people who handle them and those who come into contact through secondary exposures. Hygiene studies have shown detectable levels of cytotoxic drugs in the air of hospital areas where the drugs are prepared without proper biological safety cabinets. Workers preparing these drugs have tested positive for cytotoxic drugs in their urine. Exposure to cytotoxic drugs has been reported to cause increased frequency of chromosome damage in exposed workers. Cytotoxic drugs have also been associated with negative health effects for developing fetuses, including higher incidences of spontaneous abortions, congenital malformations, low birth weight, and infertility. Long-term exposure can cause cancer. Now, who is at risk? Anyone who works with patients receiving cytotoxic drugs is at risk of exposure and must be protected while working with cytotoxic drugs. Exposure may also occur when preparing, administering, or transporting the drugs, handling patient waste, transporting and disposing of such waste, or cleaning up spills. Anyone who may handle cytotoxic drugs or waste byproducts, including physicians, nurses, assistants, pharmacists, laboratory staff, stores, and receiving personnel, housekeeping and maintenance staff, should receive specialized training as well. Exposure can occur through skin contact, skin puncture, inhalation, and ingestion. Now, workplace management and the local health and safety committee should work together to develop specific pre-use training procedures for the proper handling, mixing, and disposal of cytotoxic drugs and waste byproducts. Eliminating or preventing exposure is the best way to protect workers. When employers cannot eliminate the hazard, they must follow a hierarchy of controls, which specifies steps required to assess and control the hazards. As you see there, we have the hierarchy of controls. Essentially, we would like to eliminate the hazard, but of course, in this situation, we can't. So the best thing that we push for is to have proper PPE. And that's the end of my presentation here, but I would like to just speak about my personal situation and my personal experience. Through research of my own, I've realized that Ontario has a cytotoxin policy, and it's been in place for many years. A NIOSH alert was developed in 2004 by the CDC, the Department of Health and Human Services and Prevention, and the National Institute for Occupational Safety, Health for preventing occupational exposures to antineoplastic and other hazardous drugs in healthcare settings. This alert was essentially developed to alert employers that there is a hazard in the workplace and outlines the steps and precautions needed in order to protect the workers who deal with these toxins. Yet we are seeing time and time again the employers are failing to do so. The employers aren't implementing these policies and educating our members about this and other hazardous drugs in our workplace. Now, this whole project came about when one of our members was receiving many claims of skin rashes, infertility, headaches, among other ailments from our members. She herself had experienced some health issues and she started to do some research of her own. She found out that the facility in which she worked at did not have any policies or procedures in place to handle cytotoxic drugs. Upon doing more research, she found out that she was coming into direct contact with many residents who were on cytotoxic medications. She wasn't notified, she was not given the proper PPE, and the education was not provided. That's where this entire project began. We began to research cytotoxic drugs in the workplace and began to educate our members about handling cytotoxic drugs and the adverse effects that they could cause. And we began to take a look at the facilities that we represent and realize there was a huge gap in the system. And we began to educate our management teams on cytotoxic drug exposure. We represent many nursing homes within our community, and we've received 165 exposure-related forms. This shows you that the exposure is widespread, and moving forward, we need to ensure our employers are flagging the medications and the residents who use this medication, educate staff on cytotoxic drug exposure and the signs and symptoms, and to ensure the proper PPE is put into place. In the event that an exposure does take place, we need to ensure our members are filling out the proper documentation and filling out the proper forms with WSIB. When this project began, I personally didn't know what cytotoxic drugs were, let alone their side effects. I had returned from a leave of absence, and I noticed some signage about cytotoxic drug exposure, but again, I had no knowledge of what this was. I contacted my Joint Health and Safety Committee, who explained to me exactly what was going on. There was still a gap though, because I found myself at work attempting to do my job and walking into a room with signage, but no education on the matter. Our employer still wasn't grasping it. I spent some time researching cytotoxic drugs and realized that this was serious and it needed a deeper look from our Joint Health and Safety Committee. We had the Ministry of Health come in and educate our management on what cytotoxic drugs are and educate them on how to properly protect the workers. Our Joint Health and Safety Committee has implemented a checklist to ensure we are regularly reviewing our cytotoxic drug medication list to regularly update it and ensure the proper procedures are being followed. None of this was in place prior to this project. Thanks to this project, my employer now has a policy and procedure regarding cytotoxic drugs. We're beginning to ensure our workers are protected with the proper PPE and that our workers are being provided with the proper education surrounding cytotoxic drugs. Thank you.
Thank you so much, Amanda, for your story. It's really important. We thought it would frame very well our next speaker and give a frontline story of how we really don't always hit the mark when it comes to recognizing hazards, let alone assessing and controlling them in the workplaces. Are there any questions in the chat, Jennifer, for Amanda?
Not at this time, no.
Amanda, stay tuned because I think it would be great. We wanted Amanda and Dr. Hugh Davies, who are our next speaker, to kind of take questions as a panel at the end of Hugh Davies' session, which is coming up next. So Amanda, stick around and hopefully we'll have some questions from folks. I hope there aren't any more audio issues that Aaron had flagged. Is everybody else hearing okay? Can we get like little reactions or a yes or something in the chat to make sure that is? Oh, great. No worries, Aaron. Awesome. Good. Thanks for the thumbs up, folks. So Amanda, if you want to stop sharing, and folks, if you think of any questions for Amanda after Dr. Davies speaks, then they can take it all on together. It's a great, well, it's a good story. So over to, you're welcome to share your screen, Dr. Davies, while I introduce you. So now we have Dr. Davies, a professor of occupational and environmental health in the UBC School of Population and Public Health, where he's also an associate director of education. He holds appointments in the Occupational Cancer Research Center in Toronto and at the University of Waterloo, and is a board-certified industrial hygienist. Dr. Davies' research encompasses the full breadth of the field of occupational hygiene, for example, hazard recognition, evaluation, and control. He's currently leading projects investigating occupational exposures of healthcare workers to antineoplastic drugs in cancer care centers and veterinary clinics, accidental exposure to illicit drugs in safe consumption sites, whole body vibration exposure in truck drivers, and the measurement and control of silica exposure in construction industry. Professor Davies is the past president of the Canadian Association for Research and Work in Health, Carwa and is currently a member of the ACGIH Chemical Substances TLB Committee. So welcome, Dr. Davies. And you've heard from Dr. Davies prior at these October sessions, he and Dr. Melanie Gorman-Ing are the brains behind the silica control tool, which was developed in BC and is now coming to Ontario. So welcome back, Dr. Davies.
Thank you, Kimberly. Can you hear me okay?
I hear you wonderfully.
Oh, okay, thanks very much. And thanks, Amanda, for that great introduction to this topic and also the perspective, your perspective sort of in the front lines. This issue of antineoplastic drugs, cytotoxic drugs, is still definitely something which is evolving, I would say. And my presentation is going to talk about a study that we conducted in Alberta and in the US, in Minnesota, with a specific intent of trying to improve how we measure and do surveillance of these drugs, hazardous drugs in the workplaces. So I think is a nice complement to Amanda's presentation, and I want to start because I often get to the end of these talks and run out of time and don't get to the most important part, which is acknowledging that I'm not the only one involved in this study. There are many other people. First of all, that it was funded by the Alberta government, the Ministry of Labour, and then we had a fantastic team, including folks who work in the health system in Alberta, Carol Chambers, who's the Director of Oncology Services, the pharmacy section, and Dr. Darcy Millard-Johnson, who is the oncological pharmacy practice manager in the mHealth Fairview system. And then my colleagues, Susan Arnold at the University of Minnesota, George Astrakianakis, who many of you may already know, here at UBC, and then our lab manager, Maddie Geronimo, a chemist who developed a lot of the methods we used, and then many students and staff who were involved. So thank them all. I want to thank them all. So Amanda gave this great introduction, which means I can really skip sort of straight to the meat of the talk. And she already indicated that a lot of the exposures of concern are these ones that occur indirectly to individuals who are in contact with contaminated surfaces and objects. And so that is the emphasis of a lot of the exposure assessment we do now is on surface contamination. And as Amanda said, that this exposure largely occurs in hospital settings, such as the nurses involved in administering antineoplastic drugs, and of course the pharmacists and pharmacy technicians preparing them, but also janitorial and sanitary workers who are handling contaminated bedding, clothing, or waste streams. And also, as Amanda said, there's increasingly occurring outside of hospitals, exposures, both in veterinary care facilities where we have done a little bit of work, but also in the community. More and more, there's more and more an emphasis on getting patients home and receiving treatment in the home, which means there's another whole group of healthcare workers that are potentially exposed. One point I wanted to add is that while the exposure levels we're talking about are very low to these drugs compared to the dosages that you would receive for cancer therapy, for example, we have to remember that these are uncontrolled exposures. They're chronic exposures, so going on for not just weeks, but in fact years and decades at low levels, and we have no idea what that kind of dosage may do. And then the other thing is that we're also talking about mixtures of drugs, again, uncontrolled mixtures, and those mixtures can include the breakdown products of the drugs that have been sitting on surfaces, exposed to light and heat and so on, and also the reaction byproducts when you try and clean these drugs off of surfaces, because a lot of cleaning in hospitals is aimed at disinfection, and those disinfections don't necessarily clean drugs, but what they can do is react with them and create hazardous byproducts. And I won't talk about that today, but our colleagues in Minnesota are actually looking at what kinds of what these byproducts might be and their hazard level. I just want to add a little bit more to the exposure question, or the exposure context. This is Carex Canada data. I just downloaded an update yesterday, and I'm sure most of you are familiar with the work of Carex Canada. This is from their occupational exposure feature on antineoplastic drugs, and it shows that around 80,000 individuals in Canada are likely exposed to these drugs. 76% of the large majority are female, and about 60% of the exposures are related to the pharmacy work, which is one of the reasons that we focused on pharmacy and nursing in this study. Now, let's set the scene a little bit for one of the objectives of our study is the regulatory efforts. And again, Amanda touched on the fact that WSIB and here in British Columbia, WorkSafe BC have specific occupational health and safety regulations around hazardous drugs. But in pharmacy settings, the professionals also rely on guidance from their regulatory bodies, such as the United States Pharmacopoeia, the USP 800 document called Hazardous Drugs Handling in Healthcare Settings, for instance, speaks directly to this issue of measurement. And just to emphasize again, this is what we were really interested in, was surveillance of exposure as a means to reduce the risk to employees. So we know from just occupational hygiene evidence that being able to measure the hazard, being able to measure the exposure is key in understanding, first of all, the risk, but then in evaluating the efficacy of controls and so forth. So this talk and our work is very much directed at improving our exposure assessment strategies and methods. So with respect to that, USP 800 does touch on exposure measurement. It talks about wipe sampling, which is the term we use for surface exposure monitoring, looking for hazardous drug surface residues. It talks a little bit about the frequency of measurement, and I'll give more detail later. And then it has language like, if any measurable contamination is found, you are to identify, document, and contain the cause of the contamination, and then repeat sampling to make sure that your cleaning was effective. So basically, it's pretty vague, and this lack of detail really hinders the end user from being able to operationalize this in an effective way. NAPRA is the National Association of Pharmacy Regulatory Authorities. That's a Canadian body. They simply refer to USP 800. And then I wanted to just mention that WorkSafe BC is actually going through a review of the section of their occupational health and safety regulation on hazardous drugs. It's out for public comment now. So if any of you at this event would like to learn more about what we're doing in BC and indeed comment on it, and I'm sure that they would love to hear the voices of you, Amanda, and others that have an interest in this. It is open for public comment right now through December the 19th, and that would be available on their website. But I wanted to point out that they have expressly steered away from an exposure assessment regulation, saying that WorkSafe BC does not recognize an environmental or exposure monitoring standard for hazardous drugs. as a regulatory body, they feel obliged to have a validated method in place before they can require employers to take measurements. And we will be making a public comment on this because I think it's up for debate as to at what point a regulatory agency should require measurement and simply not wait until there's a validated method in place. So some of the issues we're facing in this area is that there are control measures, as again Amanda said. There's personal protective equipment. There are controls, engineering controls in place, such as closed system transfer devices, CSTDs. But despite that, when we measure exposures in the workplace, we always find contamination. So, and I say we, the scientists that are measuring this around the world. And those levels seem to be fairly consistent. There are these new guidelines, but there's a lack of standard methods, strategies for how to measure. There's overall a lack of data on which to build these new methods and strategies. And there are no TLVs or OELs for any of these drugs, and certainly not for surface exposures. Surface limits are being now introduced by the ACGIH TLV committee. There's just a handful of them at the moment, and certainly none for these drugs that we're interested in this these antineoplastic drugs. In terms of methods, there are issues as well. Almost all of the methods require laboratory analysis. There are a few colorimetric kits coming on the market, sort of instant colorimetric kits. But most of the methods require lab analysis. They're very expensive. They cost around $160 US per drug, per sample, which is quite prohibitively expensive for a healthcare system, which is very short on resources and funds. And then there's technical issues, which are going to come back. I'm going to come back and talk about this later. But remember, USP talked about if any measurable level is found. Well, if you are basically looking for any measurable level, then that is going to make your method depend on the sensitivity of the analysis instrument, and that varies widely. So different labs will have different equipment with different sensitivities, and so this, what we would call the limit of detection, the lowest detectable amount, is going to vary highly from lab to lab, from year to year, and so on. Okay, so we responded to these issues and this problem by creating this project that was funded, I say, by Alberta Ministry of Labour, which we called SURFACES, or the Surveillance for Anti-Cancer Drug Exposure Study. And to address these issues, we had these two main objectives. We wanted to help characterize surface contamination by these drugs in Alberta and Minnesota cancer care facilities. We wanted to try and find out what were the determinants of contamination. So what factors were in play in terms of influencing the degree of contamination by these drugs, and how did drug contamination vary over time and space? So if you're going to create a surveillance strategy, these are the kinds of things that you need to know to then recommend to practitioners how often they should sample, where they should sample, what they should sample, and so forth. And that was indeed our second objective, was to make those kind of recommendations to support new guidelines, these new guidelines and regulations. So the study I'm going to talk about today was very large. It was 9 hospital sites. So basically all the large, or many of the large cancer care facilities in Alberta. We actually picked the 2 largest in Calgary and Edmonton, and then 2 medium size and 2 small size. And then we matched with 3 of those with our sites in Minnesota. At each of the 9 sites, we sampled roughly monthly over a whole year. And each time we went there, we sampled at 20 different surfaces. And when I talk about a surface, this could have been like a keyboard. It could have been an IV control panel. It could have been the inside of a drug preparation area, the floor in front of the drug preparation area, and so on. We sampled in both the pharmacy and in the patient drug administration area. And in one hospital, we had an inpatient ward. For every surface at every site, we sampled for 11 different antineoplastic drugs. So that created a lot of data, as you'll see coming up. But just to sort of a little bit more about where we sampled, we tried to basically sample surfaces throughout the path that the drugs took through the healthcare facility. So everything from the place where they actually opened a cardboard box full of the vials of the drugs, right through to the waste bins in the disposal area in the patient care area. The sampling was done by hospital staff. Because of the size of this study, what we did was we used a self-testing technique that was developed by Matty Geronimo. And basically what we did is we shipped a kit out to each site at each month, and they would get pre-moistened wipes, vials to put the samples in once they'd taken them, a template to use to constrain the area, the measurement area, some other tools like forceps and tapes and so on. And then training was conducted via YouTube video, and that is available. You can find it through our site. I think I've got a link to our site coming up later on. This method has been validated, and it's shown to be to get consistent results, even though you have different people doing the sampling at different times. The samples were then shipped to UBC, where we analyzed them here, and we also collected supplementary data about the conditions at the hospital on the day and few days prior to sampling. Okay, so I'm going to go into some results now. These are fairly busy slides, and I'll try and talk you through the main findings. Okay, so this slide shows the summary of the 22,000 samples that we obtained. So this is the 9 sites times the 12 months times the 20 surfaces times the 11 drugs, and some of those were repeated, so that's why we got to 22,000 measurements. The numbers here show the 9 different sites. The first 6 are in Alberta. The last 3 are in Minnesota. And the blue line, the numbers I should mention, that's the total number of samples at the site. So if we just look at site 1, you can see we took 3,091 measurements. The blue line shows you that only about 7% were measurable concentrations or above the limit of detection. So generally speaking, what we're saying there is 92% of the samples we took were below the limit of detection or non-detectable. Okay, the red shows what we call the cleaning event. So we set our own, if you like, exposure level, our own occupational exposure limit, or OEL, at 1 nanogram per square centimeter. This has been commonly used by other researchers, just to alert the sites, and we gave them instant feedback, or more so immediate feedback, I should say, on their results. If we found a hot spot that had a sample greater than 1 nanogram per square centimeter, they were informed and then able to take immediate action to clean. So what we see here is out of 3,091 measurements at site 1, only 1 cleaning event occurred over a whole year. So now you can look across the other sites, and what you can see really is that overall, these measurable events are quite rare, less than 7% overall. And overall, only 56 times did we come up with one of these cleaning events where we felt that immediate intervention was needed. What you can also see here is a very big difference between Alberta and Minnesota. And now we'll talk about the kinds of reasons for this in a few slides. But the main focus here, in terms of thinking about how to think of a surveillance method or how to improve the surveillance method, is that these are fairly rare events. And indeed, when we look at the 11 different drugs that we were testing for, you can see that the percent above the limit of detection was highest for a drug called gemcitabine. It was about 16% for cyclophosphamide. Now, cyclophosphamide, or CP, is generally or widely used as the sort of indicator drug in most other studies. And then we also looked at paclitaxel, that 13% of our measurements contain paclitaxel, and then so on down through these other drugs. These drugs, I should say, were selected because they were used at the site, not necessarily at every visit, and they were also drugs that we were able to analyze here using the equipment we have at UBC. Now, this is my busiest slide. I apologize in advance. This is a whole year's data for one site, one of the Alberta sites, for 3 drugs. Now, from here on, I'm only going to show you data for the 3 drugs, gemcitabine, CP, and paclitaxel, because these 3 were the ones that had the most data above limit of detection. Each line or each column shows you all the results at one surface. So here we have the biological safety cabinet work surface, the clean room cart. So this is basically following the flow as you go from left to right of drugs through the hospital setting. You can see it goes from pharmacy to nursing at about sort of 2/3 of the way across. And what you can see here is green circles are gemcitabine, black triangles are cyclophosphamide, blue squares are paclitaxel. And if it's hollow, like this square down here, that means it was below the limit of detection. And if it's solid, that means it was above the limit of detection. Okay, so what can you take from this? Well, the y-axis is the amount we found in a log scale. So each bar is 10 times greater than the bar below it. So what you can see here, for instance, is the biological safety cabinet. This first column here is quite compact, so not much variation, and it's quite low. So this is perhaps understandable in the sense that this is where drugs are prepared. And so this surface gets a lot of cleaning. And you'd expect it, therefore, to be fairly clean. And when you surveil it, you don't find much. On the other hand, if we go out to the other end, what we find, for instance, here, now this is the patient area and it's the washroom toilet handle. And what you can see is that not only do we have a lot higher exposure levels, so this is 1 order of magnitude, 2 order of magnitude, 3 orders of magnitude higher than where the drugs are prepared, but there's also a lot of variability. Okay, so this could be, for instance, because of the obviously it's a contamination event. This is a secondary contamination event. This is either a worker or a patient who has got contaminated hands, perhaps because it's been in contact with bodily fluids while using the toilet and then touching the toilet handle. And then there's a randomness that comes into, for instance, how often that is cleaned. You can also see the patient washroom door handle was one of the more contaminated areas. Oops. As was the handle on what's called the pass-through and the handle on the fridge. So you get a pattern here that where hands are touching, this is a place where we tend to see higher and more variability in measurements. Okay, so in this slide, I'm going to move on to what we call the determinants. So what factors influenced the different levels that we saw? And as we notice, so the way you would read this, I'm just going to focus on the gemcitabine column, this here. These are odds ratios or risks. So an odds ratio of 1 means there was no difference. An odds ratio greater than 1 means that there was a higher chance or likelihood of detecting drugs. So here we're saying, if we take Alberta as the reference level, Minnesota, we were 4.6 times more likely to find drugs in a Minnesota sample. Now, I mentioned that when we saw the graph, they were a lot higher. This is probably due to, or we think largely due to the use of these CSTDs, the closed system transfer devices, or an engineering control that should theoretically reduce contamination of surfaces and then secondary contamination. But of course, they're also talking about very different health systems with different training, different regulations. So there's a lot going on there. It's difficult to unpack exactly why there is that difference, but it's very clear. Okay, so just quickly then, we can also see that surface location matters. Comparing the drug compounding area, which is the biosafety cabinets and the tables around it, the rest of the pharmacy area is actually at the highest risk. So close to where it's compounded, but just beyond the clean room. The amount compounded is important. So at least up to 10,000 milligrams per 48 hours, as the level of amount is compounded goes up, we find more contamination. The number of patients seen, not surprisingly, the more patients that are seen in a site, the higher the exposure. This is looking at the effect of time. So the later in the study, the lower the levels of exposure got. This might be related to what we would call a training effect, that we were actually having an impact on the site, that it was actually getting cleaner as the study went on, but it wasn't that consistent across drugs. And then lastly, workload, when we asked for a subjective evaluation of how busy were you, which isn't quite the same as the number of patients seen, we also saw that the heavier the workload, the more likely we were to have an exposure. So that would make sense. If people are busier, then there's probably less cleaning going on, and maybe perhaps less attention to preventing spills and contamination. Okay, so the main findings then of this exposure study were, that we did find contamination pretty much everywhere we looked. Now, we looked for two different things: detection, which was that issue, that idea of any measurable amount. We called that detection. Contamination was, we were looking for higher exposure levels. So what we did there is we measured those that were in the highest 10 percentile. So the very sort of most, the largest exposures. And what we found, there was a different pattern. I didn't show you the results there, but essentially what we saw was very low level exposure all the time, and then occasional peaks, which were probably caused by spills and poorly cleaned spill events. Our exposure levels on surfaces were comparable with other Canadian studies, and I've been through and talked about some of the reasons why we saw variability. And all of this is, if you want to find out more, is published a couple of years ago in the Annals of Work, Exposure and Health, and those details are there. So I want to go on now to what I think is the most exciting part of this, is actually applying what we learned to help frontline workers and agencies and employers to improve their monitoring, improve their surveillance of this hazard. So I just want to dig in a little bit deeper to the current guidelines. So I mentioned USP 800 earlier. This is, again, this is not quite verbatim because there's not enough room on the slide to put it all in. But the USP 800 recommends sampling routinely. So then they say, e.g., a benchmark, and then at least every 6 months or more often as needed. And then they give these very specific sampling areas, such as the interior of the prep cabinet, the pass-through chambers. This is the chamber between the drug prep area and the rest of the pharmacy, and so on. So these 5 or 6 very specific sites. There's no information on the specific number of or size of the wipe samples at all. They recommend some common marker drugs like cyclophosphamide, ifosfamide, methotrexate, 5-fluorouracil, but that's all they say. They do mention that there's no standard for acceptable limits, i.e. no TLVs, but they do talk about this 1 nanogram per centimeter cubed, which you saw we used as well as a possible marker. And then they talk about if any measurable contamination. I've talked about the problem with that statement. So this is currently what our hospitals and pharmacies have to use. So we were interested in how can we improve on that? Well, we know that there's no TLV to compare to. So that's a problem. And something else we noted in our data and others have before is it's what we call highly censored data. That is, a very large percentage of the measurements are below the limit of detection. Now that means that you can't appropriately come up with a mean level, an average, because the data does not follow the distribution, the underlying distribution that makes an average make any sense. You've got mostly unmeasurable or below the limit of detection data, and then a few, around 7% of your data, actually has a value. So that means even if you did have an OEL, it's kind of tricky to know what you would compare it to. The problems with talking about detectable or measurable levels I've mentioned. The LOD, the limit of detection, is highly variable. It varies between drugs, between different analytical runs, different labs over time, and so on. So using the limit of detection as a measure is not ideal. So one of the things that's been proposed in this field, and I like it for a number of reasons, is this idea of what's called a hygiene guidance value. And it's really based on your own data or the data that you find from other sites. So in other words, based on your own data or use other reference data. And the idea is that you set a limit based on the 90th percentile of your own data. That means that you're always going to be trying to aim for a number which is lower than your current exposure data, your current exposure level. You're always going to be aiming to basically reduce it by 10%, if you like. So if that's your aim, then every time you go ahead and make more measurements, you should be trying to get it below the 90th percentile of your last measurement. And if you don't, you go ahead and make changes to reduce it. Okay, so essentially this is like constant improvement, and that is an important concept for ALARA. I mean, really, it would be good to apply this to everything we do. If we're always striving to improve every single measurement and reduce it, we are essentially on a path to constant improvement. So what we did is we took our huge data set of 22,000 measurements, and we said, well, what if we tried now to simulate many different kinds of sampling surveillance strategies? And so what we did is we used statistical analysis, and we simulated as though you were going out and doing 10,000 different samples for many different types of permutations. And what we changed was, well, what if you sampled 2 surfaces? What if you sampled 5 surfaces or 10 surfaces? How much more effective is your surveillance by varying the number of surfaces? And remember, the current guideline does not tell you how many surfaces. It suggests 5 or 6, but it doesn't actually tell you how many you should do. So part of this coming up with a new sampling strategy was actually to sort of evaluate what the USP recommendations are. We also looked at whether there was a difference between sampling on a monthly basis, quarterly, semi-annual, or annual. Remember, USP suggests semi-annual to annual. We also looked at the number of drugs. USP says nothing about this, but practice has been to look at one drug, typically cyclophosphamide or 5-fluorouracil. But what we did is we looked at each of our top 3 drugs that we found, paclitaxel, gemcitabine, and cyclophosphamide. And then we also looked at as though you were looking at all 3. So what if you looked at them all individually, or what if you looked for all 3? And then lastly, we looked at what we called random surfaces, which was just people going out and picking surfaces within their clinic at random, versus those that were selected because they were previously known to be contaminated, and we called those sentinel surfaces. And then we looked at 2 different outcomes. We looked at this detectable versus non-detectable, and then we looked at this HGV, or the 90th percentile. So what these slides show, I have 3 of these slides. I won't expect you to look at every single data point on them, but I just want to show you. So this is, oops, I think I've gone by, sorry, I might have gone too far. Yes, here's the first one. So these are the randomly selected surfaces. Okay. Oh, sorry. These are the randomly selected surfaces. On the x-axis in each box, you've got the number of surfaces sampled. So let's just look at the top left. This is increasing the number of surfaces sampled of random surfaces. So 5 random surfaces, 10 random surfaces, 15, and so on. This is the probability you'd actually detect a drug. Remember, based on our own data. So this is based on the data that we collected from those 9 sites. And what it shows is if you were just looking for paclitaxel, that's the purple line, and you just did 5 randomly selected surfaces, based on our own data, you'd only have a 50-50 chance of showing a positive result. Okay, so in other words, if you were doing the USP annual surfaces, just 1 drug, well, let's take CP, which they actually would recommend. CP, 5 surfaces annually, you'd only have about just over 50-50 chance of actually finding a true positive. If you sampled 10 surfaces, you'd be up to about 80%. You wouldn't get up to guaranteed finding of a true event until you went to about 20 surfaces. So now if you look across at semi-annual, you can see for just cyclophosphamide, CP, which is the green, 5 surfaces, sorry, would again be about 75%. So you'd still be missing 25% of the time a true positive. Okay, so I'm going to move on to the next set of slides. So now if you picked sentinel surfaces, what happens? So now you're using your own data that says these are the more contaminated sites, not the sites that USP 800 said, but your sites. So like a toilet handle, for instance. Now, if you just did 5 sites annually for CP, you'd be up around 75%. So that's a good gain on random sites. And you'd only have to go up to 10 samples to get up about 90% success rate. Okay, so sentinel surfaces is definitely going to be better than random surfaces. And if you did it semi-annually every 6 months, your chances of finding a true positive now go up to over 90% for just 1 drug. Now, what you've seen throughout all of these slides is if you look for a panel of 3 drugs, that's the red line, you get a lot more bang for your buck. Now, you're going to spend more bucks, that's the problem, but your efficacy goes up very quickly. You can see that quarterly sampling and monthly sampling of sentinel surfaces are very, very good. Okay, so I'm going to go on to my last results slide. This is this 90th percentile, or HGV. Now, the 4 slides here now show what we've got: 5%, 10%, 20, and 30%. Now, what this is saying is, in the true, what we've done is we've said, if the true case was that 30% of your measurements, so we're bottom right now, 30% of your surfaces were actually contaminated, this is the probability you would find a positive. Okay, if you did 5 measurements of 3 drugs, you'd find a positive measurement, okay? But if you only looked at one drug, now all three drugs actually follow the same curve here, which is why you end up with this one purple line. You'd only have about 80% chance, even when 1/3 of your surfaces were actually contaminated. You'd only have about about an 80% chance of detecting that. Okay. Now, the reason we've gone 30, 20, 10, 5 is, remember I said this is continuous improvement. So if you were starting at 30% in year 1, you'd hope that the next year you'd be doing better and you'd be at 20%. And the next year you'd be doing better and only 10% of your surfaces are contaminated. And then finally, after several years, you'd be up in this top left corner where very few of your surfaces were contaminated. And you can see that it becomes increasingly hard to detect them because there's fewer of them. So again, what this shows, though, is the benefit of looking for multiple drugs. If you look for 3 drugs or more, you're much more likely to find a positive. Okay, so this has just been published this year in a paper by Susan and the rest of our team in the Journal of Oncology and Pharmacy Practice. And we made these recommendations. Now, there are limitations. Of course, this is one study. It's very specific to Alberta, Minnesota. But on our data, we basically said we think you should evaluate a panel of at least 3 drugs. You should use this sentinel surface approach on at least 5 surfaces. 10 gets you a lot more, is a good investment, but beyond 10 you get less of a benefit. At least semi-annual sampling, and we would recommend the use of these hygienic guidance values over simple detection or non-detection. So, in conclusion, I just want to reiterate that antineoplastic drugs, of course, are going to be with us because they're incredibly important in the therapeutic treatment of cancer. But clinical and pharmacy staff, as Amanda said, are at great risk of long-term low-level exposures. Regulatory bodies are increasingly recognizing the risk, but don't give us provide adequate risk assessment guidelines, especially around measurement of exposure. And our study showed exposure over a number of hospital settings in 2 different regions at numbers that could be said to be typical. And then finally, we use that data to inform and improve risk assessment guidance. And so thank you for listening, and I'm happy to take questions.
Thanks so much, Hugh. This is amazing. And Amanda, I'm interested. We will take questions, and Jennifer, if you don't mind asking those on our behalf. And Amanda, I am interested in your response to Dr. Davies' session as well first. And folks, we have Amanda here and Dr. Davies, so we have, it's great to have both a workplace and a science and research, and we can see the gap, and hopefully we can fill that. So there's a couple of comments, but Amanda, do you have any questions for Dr. Davies?
I don't have any questions, but I think it's very interesting. And actually, I do have a question. Is the sampling a possibility to do at our different sites, or is that like too expensive? Or
yeah, well, we're constantly looking for opportunities to do additional sampling. We did recently complete a study in veterinary clinics, which hasn't been published yet, and we are working with our colleagues in Minnesota to try and start a study of home care settings and other sort of non-hospital based settings. There's a cost per sample, as I said. We actually can do it a lot cheaper than the one I quoted. I think we generally, our costs for our study have been about $200 Canadian for all 11 drugs or any subset. So compared to 160 US per drug, it's a hugely cheaper method that we have here, but it's equally sensitive and valid. But even so, we can't do sort of one sample at a time. We really there's an overhead as well. So we should keep in touch. And we've done studies for BC Cancer on request. We're doing some work with Fraser Healthcare here, one of our health regions. So opportunities are continually coming up. And we'd look to include anybody that wanted to collaborate with us. Yeah.
And it's just interesting, like, just to see the evolving nature. We wanted to bring this subject matter because it's such an emerging issue, but at the same time shouldn't be. And just to show the polarity between, we've been talking diesel and silica and contaminants where we know the health effects. We have something to measure. We have a way of measuring it. We have a way of comparing it. We have OELs even if they're not the ones we would like them to be, but there are lots and lots that we don't have all the answers to assess exposure to. And so was really important for us to bring this subject to the table. So Jen, is there questions in the chat for us?
There is one question. It says, is there any data that correlates surface wipe results with biological indicators of exposure, for example, worker blood or urine sampling programs?
There is. It's not work that we have done here, although one of my colleagues who used to be here, who's now at Toronto Metropolitan, Chun Yip Hon, I think might have done some of that work many, many years ago. So you might want to reach out to him. We're excited. One of our colleagues, or my colleague Susan Arnold, who's at University of Minnesota, is working with one of her colleagues to look at DNA markers, as coming up with this very specific biomarker for these exposures. The work comes from the pharmaceutical side, where they're looking at personalized medicine options. So one of the things they want to do is look at how these drugs are targeting different cells and different structures in cells. And so essentially they're creating something that we can use on the occupational side as a biomarker. So I think that is definitely a trajectory of research that is going to be very interesting in the future.
Thanks. And I'll just shout, Jen, if you have others. I do want to again point out how important the worker voice is in issues like this, because when we don't have all the answers, we need to be collecting. You believe you were exposed to a hazard. Here's what work and work processes we think where the exposure was highest. Then we can merge with the science and the research and translate that back to you for practical solutions. So I hope that's the message that we're getting across today. Anything else, Jen?
Yes, there's one more question in the chat. Are there any restrictions on the transportation of samples with your method regarding cold?
Oh yeah, that's a very good question. Yeah, so I mentioned that the method we used was validated. So Maddie Geronimo and his colleagues in the lab did test all those kinds of things. Shipping, transportation of samples is a big issue because the temperatures in Alberta, as you know, go up and down throughout the year. Cold was not so much a problem. Most of these chemical samples, we'd rather have them cold or frozen. But heat in the Alberta summer was a problem. We didn't want boxes sitting sitting waiting for a courier to come and pick them up at the loading dock, baking in the sun. And so we did actually have very strict shipping guidelines. They had to be shipped in a way that we knew that they'd get here within 48 hours, although most got here, I think over 90% got here within 24 hours. And that was well within parameters that we could deal with. These samples could sit, I think it was something like 10 days at room temperature without any degradation. And then, of course, we have internal samples that we run here at the lab that also help make sure the QA/QCs are followed. Yeah.
And Hugh, I'm not sure if your lab is doing research type on the sample, but can you talk about hygiene labs across Ontario that would be available to
Yeah, to my knowledge, there aren't any. We do work for instance, Metropolitan University of Toronto. They send their samples to us for analysis. The IRSST in Quebec has I think it's the IRSST. It's definitely there's a Quebec-based lab that does this exact same work. Very high quality. They publish as well, and they use a very similar method to ours. I mean, we would welcome to do service work. So, if there are folks on the call that, are in a hospital setting, like I said, we do work for BC Cancer here, who want to set up a service contract, non-research, we're happy to talk about that at any time as well. I shouldn't have, we definitely welcome service work as well. Yeah.
Great. And Jen, while you look for the next question, just pipe in. I'll mention again just the the importance of, let's put our efforts to controls as well, right? This is a lot on assessment, but we know, and especially your research showed, Hugh, around, we know, look, Amanda told us she was doing work, didn't know that this was even present. So I'm sure with the amount of work that they have to do, no one's slowing down and doing any proper cleaning. I mean, they didn't even know the hazard existed. So we have lots of steps to put in place before we need to get to labs and measurement. We need to, learn about the hazard. We need to control it through proper cleaning and procedures, as Amanda was stating. And of course, assessment, we don't want to skip steps either. It's very important, but if we don't have that type of availability right now or something to compare it to, it'll probably be a good evaluation of our procedures. But we need to be cleaning, we need to be controlling the hazard, we need to make people aware of it. So Jen, over to you if there are more questions.
Yes. Do you have any data for the airborne exposures in addition to the surface concentrations you discussed?
Yeah, in our study, we didn't look at airborne contamination. It's not thought to be as a larger contributor to overall exposure as dermal contamination. So it's not as widely explored. So I think in other settings like manufacturing, you will see more possibility of aerosolized exposures, and but in the settings like healthcare, it's predominantly the dermal contamination that we're concerned about. And just to go back to your point, Kimberly, about controls, I mean, it really is an area that needs a lot of exploration. I was not aware until we went out and did some site visits that there are specific, and this shouldn't be a surprise to me, a hygienist, there are specific gloves that are used when handling antineoplastic drugs. And I saw boxes of gloves that said not for use with antineoplastic. So even selecting the right glove, and as I mentioned, the right cleaning agent. The fellow's name in University of Minnesota is Andrew Floder. He's looking at what happens when you bleach one of these drugs. You may disinfect all of the biohazard off of a counter, but what have you done to all of the toxic drugs? Because if you chop them up into little pieces, they're now drugs or toxins that no one's ever seen before. They could be even more toxic than the parent compound. So coming up with the right cleaning agent, decontamination is really important as well.
Excellent. Amanda, do you have any input on the glove usage?
Yes, actually, at my site specifically, when they first set up the PPE, they gave us the wrong gloves. So that's where we see the break. It's not that the employers, they don't know what they don't know, so we tell them, but it's to give us the proper PPE. Even the gowns, we were getting disposable gowns, but they were permeable. They need to be a specific gown for antineoplastic drugs as well. So this project and all of this knowledge is helping me and our union and everybody else just move forward and ensure that we're getting the proper PPE.
Wonderful. Any other questions for Amanda or Hugh?
Nothing in the chat at this time.
Great. Well, if it, last call.
Yeah. One question here says, have you done any sampling of patient skin, clothing, bedding, etc.?
Good question. We did not. Our method is not validated on soft surfaces. But interestingly enough, our colleague, again, Andrew Floater down in Minnesota, is doing a study in veterinary clinics as well. He's actually looking at the coats of the dogs, the fur of the dogs that have been treated with antineoplastic drugs. So he's helping us validate. He's actually finding some very interesting things off of dog coats. So we think we may go back and revisit that. But no, we didn't in this study look at any of these soft tissues or materials. I will just tell you one little interesting story though. At each time we sent a kit out to a hospital, we gave them the 20 surfaces we wanted them to monitor, and we gave them very explicit instructions. But then we said, if there's something that worries you, take a sample and send it to us and we'll analyze it. So we got a sample that was really hot, had high contamination, and we looked to see what it was, and it was a pen. And we were like, well, that's no big surprise. They've got a contaminated pen. That makes perfect sense. So we told them, but of course they hadn't kept the pen. So they didn't know which pen was toxic. So essentially they had to replace every pen in the clinic because they couldn't remember which one they tested. But it just shows you, and that was a pattern I pointed out. It tends to be, you see, it's these dermal touch points, which tend to be hot in terms of contamination. And we did see people, trainee nurses, operating IV pads, the control pads with their gloves on, and then being shown by an instructor who would just walk by and show them how to do it without gloves on. And you can see how these transfers could be very hazardous very quickly, going from a gloved hand to an ungloved hand and so on.
Great, thank you. So we're going to switch gears now, and thank you and Amanda very much for their presentation. We're going to move on to other occupational exposures and community responses. If there's no further questions, thank you so much, Hugh and Amanda. Such great insight. We're now going to move on to a couple of important speakers from our community health workers through the Healthy Worker Nail Salon project, Jackie Liang and Cate Ahrens. And Jackie is a community health worker and a nail technician. She has been working in the nail sector in Toronto for the last 12 years and has been involved in community work for 9. She immigrated to Canada in 2007 from an industrial area in the province of Yin in mainland northern China. She was trained as an electrician, but as jobs were scarce and economic downturn, she trained to be a hairdresser and an esthetician, skills which she brought with her to Canada. Before leaving China, Jackie worked as a kindergarten teacher. In 2010, she started working in the nail salon sector in Toronto. Since 2013, Jackie's been working as an outreach worker with the Nail Salon Workers projects at the Parkdale Queen and West Community Health Centre. And Jackie's work involves community engagement and carrying out health promotion activities in nail salons throughout the Greater Toronto Area. She's a work environment with This is a work environment with high level of toxic exposures due to the products used in salons. Jackie believes that until better ventilation is made mandatory and nail products contain fewer toxic chemicals, she can help nail technicians to protect their health. She's also worked on projects with Ryerson University, is focused on health issues faced by precarious workers. In recognition of her work with the Nail Salon project, Sorry, something's happening with my computer. The important contribution she's made to Chinese Canadian community in the GTA. Jackie was awarded the Chinese Canada Achievement Workers Award, presented by the Chinese Canadian National Council in 2018. Jackie lives in Toronto with her husband and her 7-year-old son. And we have Cate as well. Cate Ahrens is a health promoter at the Parkdale Queen West Community Health Center. She supports primary health care and health equity strategies and initiatives. Cate's been a co-lead with the Nail Salon Workers Project at the health center since 2014. This work has included program development and evaluation, supporting worker engagement, building educational resources and learning opportunities, and fund development for continued support of the project. Cate's also the co-chair of the Healthy Nail Salon Network and the Workplace Health Without Borders Nail Salon Working Group. So Cate has a Bachelor of Environmental Studies and a Master of Education and has worked in the community health sector since 2010. So welcome to you both. And just a shout out to Victoria Arundale, our friend in the OC Illness Prevention Steering Committee, who suggested this topic today. So thank you.
Thank you for introducing us. Can you hear me?
You sound great, Jackie.
Okay, thank you. Yeah, good afternoon, everyone. My name is Jackie. I'm a nail technician and a community health worker at the Parkdale Queen West Community Health Center. I'm glad to be here with you today to talk about our project. Yeah, Kate, I pass to you.
Hi, everybody. I'm Cate. Nice to be here, and this presentation will be quite different than the other two. So really curious to hear your questions and your input on what we have so far.
Are you all right, Jackie?
Just had the problem to move in the PowerPoint. Yeah. Oh, here. Okay, try here. Yes, it works. Yeah.
All right, so we're just going to start with an overview of who the workers are in this sector. Mainly women, newcomers, racialized, have no job security, low wages, speak English as a second or third or fourth language. Many are in their childbearing years, so the impact of the work also impacts their pregnancy and babies. Many enjoy the work and want to make it better. And as so many people did, this sector and the people in it experienced massive and ongoing impact of COVID-19 as the sector shut down. Next slide, please. The discount nail salon, whoops, we'll go back one. That's right. The discount nail salon environment, it's a large industry with so many people are affected. The products used are underregulated, not well understood, and the chemicals in these products are linked to significant health risks. The jobs within the sector are precarious. Technicians and owners have a lack of training and licensing, and there's insufficient regulation and support to protect the workers in these spaces. They're predominantly small workplaces, often 1 to 3 technicians. Sometimes, and actually in many cases, an owner is also a technician, vice versa. Wages aren't being paid on time in many cases. The wages don't account for the actual hours worked and fall well below the minimum wage. And now, in response to salons being closed for so long during the pandemic, we're seeing many technicians going underground, operating out of their homes and clients' homes, so are harder to reach and are facing new and different challenges. All right, next slide, please. Great. So the work at Parkdale Queen West Community Health Center started in 2013 or 14 with health promoters seeing a link between nail technicians and health issues being presented. So the first project, funded by Women's College Hospital, was set up to connect with nail technicians and find out about their understanding of the health risks they face and what are the barriers to reducing those risks. So it involved focus groups, shared art projects, hiring peers from within the community. And then from there, we were funded by the Center for Research Expertise in Occupational Disease to pilot some education and training out in salons. So that project piloted the peer-led model, where we would hire people from within communities, provide education and training, and then that outreach team was really the link into communities firsthand. And that really became the foundation of our work that continues today. Also through that initial work, we learned about other agencies working on related issues. And the group of those agencies identified a need for a network to tackle these issues together. So that became the Healthy Nail Salon Network and is now called the Healthy Nail Salon Coalition. And by bringing nail technicians together through those initial projects, nail technicians also identified a need for united action and formed the Nail Technicians Network around the same time. And Jackie's going to speak more about that shortly. Oh, that picture on the left there is talking about the video that came out of that first Women's College Hospital funded project. So if you go onto our website, and we'll pop that in the chat afterwards, you can see a great video about where the research and where the work started. And there's a number of other videos there too. Next slide.
Yeah, I'm going to talking about the 2021 to 2022 nail salon worker project areas. We will talk about 5 areas from our work: is worker engagement and organizing, education and training, advocacy, research, network building. First, I'm going to talking about worker engagement and organizing about the Nail Technicians Network. First, I will give some Nail Technicians history and purpose. Nail Technicians Network, we call it NTN, was initiated by nail technicians with the support of the Chinese Southeast Asian Legal Clinic and the Parkdale West Community Health Center in 2017. Forming the NTN was suggested by nail technicians back in 2014 during an all stakeholders meeting. NTN is a platform for nail technicians to network, problem solve, and support each other to deal with workplace issues. We organize a range of free workshops and activities for nail technicians to socialize and improve their working conditions and skills. Our team, we have experienced 2 Vietnamese, 1 Mandarin, and 1 Korean speaking outreach peers to do outreach. Community language have to decrease the language barrier when we outreach to the nail salons, and we'll make sure the health information is delivered correctly and build relationships smoothly with nail technicians and the salon owners. Outreach and outreach strategies. Outreach is a foundation of NTN. Through the outreach, we can understand the conditions and difficulties of nail technicians they are facing and develop appropriate services for them. Outreach peers outreach to the nail salon with materials to promote our network, deliver health information, event, and webinar flyers. Provide nail technicians with updated information on regulations or other information related to the sector, and offer support. Mobilizing nail technicians and building relationships with them to find out the needs of the nail technicians. We use different strategies to attract nail technicians to join our network. Worker-related topics like trendy nail design, Mani and Tidy 101, and working relevant communication skills. We use promotional items to reach them and identify potentials, making calls to maintain the relationship by checking their needs and providing support. We also use the social media to connect and organize nail technicians, like we use in the Facebook and WeChat. Past and current work. In the past, we published the newsletters and create a Facebook, WeChat, NTN logo, and business card. We successfully organized the trip to Central Island, and the educational workshop include nail skills, English Conversation, and the Employment Standard Act. The survey had created to understand their working conditions and other issues faced by immigrant women working as a nail technician in the nail salon. We started membership to get people to join NTN, to help to take responsibility and help NTN to move forward and decide priorities. Let more nail technicians get to know us. During the pandemic, we call nail technicians to give them emotion support and update some new information, such as CRB and rent subsidy, and help them apply if they are qualified. Outreach into the nail salons during the reopening. We brought a COVID safety poster and the Ministry of Labor, Health and Safety at Work poster to the nail salons that required the nail salon to post. Workshops and follow-up webinars like CRB, and EI information session in a different language. And safe reopening workshops and follow-up session. We also cooperated with Toronto Public Health, delivered vaccine webinars in different languages. And also did legal advice for nail technicians and other issues webinars, and how to handle customers who refuse to wear a mask and don't know what to do if they are threatened to sue the salons. And we also had a photo voice project and collaborated with Occupational University. And the photo voice project aims to give voice to the nail technicians during the pandemic. We asked the nail technicians to take photos to reflect how the pandemic has affected them. Through this pandemic, through this process, the nail technicians express their opinions, feelings, and thoughts through their photos. We also created a digital album of photo voice and had exhibition. Current work, we focus on rebuilding our base through outreach and organizing because the pandemic impacted the sector tremendously. A lot of our members have to transit to other sectors to make money due to financial pressure. Recently, we organized social events like going to the zoo and salmon run to attract nail technicians, to get out to meet other nail technicians. Now we are planning an in-person Christmas party for this year. And this picture is from 2019. The nail technicians celebrated Christmas together, and it was very successful and a fun party. Unfortunately, the last 2 years Christmas party we held virtually due to the pandemic. And beside the picture is a Nail Technicians Network business card. And the picture with balloons that we were at the Nathan Philippe Square to raise awareness of health in the public. The picture with the NTN banner, it takes from the exhibition of the photo voice. Education and training. The project provides the occupational health and safety workshops, including modules on reproductive, ergonomic, skin, and respiratory health. Also workshops on labor issues and anti-aging system. Project staff and partners have created multiple print resources and an occupational health and safety guide tailored to nail salon work. During the COVID-19 pandemic, webinars include mental health support, responding to anti-aging racism, understanding regulatory change in salons, and protecting yourself at work. We also delivered vaccine webinars, safe reopening webinars, and cleaning, disinfecting, mask, and ventilation workshops. You can see the picture is the left side is we create this occupational health and safety book for new technicians, and this book is based on the reproductive health, ergonomic, skin, and respiratory health of these 4 topics to create. And the picture of the right side, I was deliver the healthy workshops. This is our new resources and materials. And we developed a new technician's guide about responding to racism at work due to the increased anti-Asian racism during the pandemic. And this is another source we created is COVID-19 safely disinfecting your nail salon, because nail technicians are already exposed to a number of chemicals in their daily work. And knowing how to use safety cleaning and disinfecting products are very important to their health.
Sure. So another project area is advocacy, and the project works with community agencies, legal clinics, academics, public health, the list goes on, and includes nail technicians to advocate on issues faced by nail technicians at multiple levels. So one example at the municipal level, we were involved in new licensing regulations back in, I think, 2015. And pushing for body safe standards to protect the health of nail technicians as well. At the provincial level, we've responded to Employment Standards Act violations and advocated for better support to vulnerable sectors around working conditions, regulations, and requirements. And at the federal level, we're advocating for better chemical regulation and enforcement. One example is methyl methacrylate that was banned, I think, in 2013. Probably someone in this group knows this better than I do. And you can still commonly find that in products on the shelf and in salons. Jackie, do you want to talk about these pictures?
Yes, and this is a left side of pictures. We were in the Status for All rally, and beside, is a right side is up one is I was with the WAC to visit MP to talking about the workers' issues, and under this one, we were at the anti-Asian racism rally. Yeah.
So one of the things we do as part of our advocacy initiatives is, yes, people in our paid positions and with agencies behind us take the lead on some of these things, and we also, take guidance from within the community about what issues we should be tackling and working to build people's comfort level and sense of agency in terms of speaking out on the issues that they are affected by. And so that's part of it that's, struggled over the last couple of years for sure, but building leadership, bringing people out onto the ground and getting more comfortable in those spaces and understanding kind of the ways advocacy works in Canada and the differences in safety and speaking out and having a voice. Next slide, please.
Yeah, I want to give some examples. Yeah.
Okay, sorry, cut you off.
During the pandemic, we invited other organizations staff with a rich experience to talk about the issues, to deliver a series of workshops for nail technicians, to increase their understanding of the social issue and how to respond to racism at work. After the workshop, we also provide opportunity for nail technicians to practice by joining the anti-Asian racism rally, and they can build more confidence in dealing with the issue and meeting other organizations. And in September of this year, we called nail technicians out to join the Status for All rally, join the marching group to let nail technicians feel the power and get their voice out and show solidarity.
Research is another project area. We've had some terrific partnerships with researchers at the University of Toronto, Toronto Metropolitan University, York University, and OCAD-U to study issues relevant to nail technicians. At the moment, we're part of a SSHRC-funded project led by Victoria Arundel at the U of T. That's a broad-scale approach to improving working conditions in the nail salon sector and addresses the discrimination technicians face based on race, gender, and class. And you can see examples here, these pictures of media attention that came from occupational exposure research led by our partners at the University of Toronto and funded by the Ministry of Labour. I think that was back in February that this got a lot of attention, but a good example of how we can be that bridge between the community and bringing people's voices to the forefront, partnered with our amazing academic partners that can do the science behind these risks. And that's Jackie in all those pictures. So that's the person you're hearing speak today, and you can see our faces during the question period as well.
Yeah, I'm so proud of myself. Yeah, it can represent some of the technicians' voice. Yeah, to talking about the chemicals.
Let's go to the next slide. Network building is a big piece of what we do. We're certainly Parkdale, Queen West, CHC, and our related networks are Toronto-based, but the project has built connections within Ontario, in other provinces, and across the US to support the work. Through these connections, we learn from others doing similar work, gain access to relevant research and issues arising, amplify the issues, and share strategies and resources. Parkdale Queen West is the co-chair of the Healthy Nail Salon Coalition, that group that we talked about forming back in 2015. And that coalition continues to be a critical part of the work. The issues are so complex, and it really does require a range of skills and expertise to respond. And that's what the coalition is really able to provide. And we also co-chair the newly formed Nail Salon Working Group within Workplace Health Without Borders. And thank you, Kevin, for putting that link in there for us. And I think, yeah, next slide, please, Jackie.
Emerging worker leaders. One of the things we focus on is capacity building and building leadership within community. So I would like to share my story about how I was involved in the Nail Salon Workers Project and how my roles have changed in the past 9 years. In 2013, Parkdale Queen West Community Health Center started a Nail Salon Worker Project. And I got a chance to join the project as an outreach worker. Since then, I have learned a lot from this project, especially the importance of knowing how to protect myself and my family. We were also trained by health professionals to deliver health workshops in nail salons. In 2016, I worked on a research project with Ryerson University that focused on health issues faced by precarious workers. This research enriched my knowledge about community-based research. I was involved in helping to build a nail technicians network in 2017, which boosted my sense of community and belonging. In 2018, the team went to California and joined the Nail Technicians Convention to meet, share, and learn from the nail technicians of the US group. I was awarded the Chinese Canadian Achievement Workers Award presented by the Chinese Canadian National Council in 2018. In 2019, 2 years of contract for the coordinator position of the Nail Technicians Network supported me in working to a community health worker. In 2021, I got a permanent position as a community health worker to help promote the Nail Technicians Network and organize workshops and activities for nail technicians and other social events. I'm so grateful for this solid position, so I can keep going to focus on supporting nail technicians, and they can count on me too. The left side, the video picture, we made this during the pandemic to promote our network and let new technicians to know who we are, what we do. The right side is the purple one is the digital photo voice album, and the under is the NTN photo voice opening speech. And Kay will check the video links in chat, and you will see these videos and our other videos. Yes, this is our project, New Salon Worker Project. Thank you so much for your interest and attention. Here is our contact information, is emails and the phone number, and yeah, feel free to contact us. Thank you.
Thank you so much, Kate and Jackie. Amazing. I mean, we are here to help empower workers. This project has shown that your stories are so, give us strength. And it kind of tying into the previous presentations, with, the lack of knowledge about the hazard versus, some of the hazards that you're encountering here, and all the work you've done to really build the partnerships between community health, public health, occupational health. It's really inspiring. So I really want to thank you for coming, and all the work we're doing at the Illness Prevention Steering Committee, and to your point, Workplace Health Without Borders, many of our partners, is to really look at equity, really ensure we're hitting. I mean, a lot of our clients are organized, and this is not the case. That's where we don't have organized support for workers the way that you've shown us, Jackie and Kate, and we need to reach out to our community partners to make that happen. It really, anyway, thank you. So over to you, Jen, for some questions, and if people have questions, please do throw them in the chat window, or come on if you like. It's a small group today, so come on, unmute yourself and ask away. But Jennifer, over to you.
Sorry, Kim, just to jump in, Kimberly, I just wanted to add and sort of build on what you were saying, is that as the sector was so fragmented and went in all different directions and was further isolated over the last couple of years, I mean, bringing people to the table to talk about occupational health and safety and labor standards was challenging before that. And now that people have really gone into survival mode and, trying to focus on just like, okay, it's all right, I have income now, don't complain about the rest, to sort of that self-preservation mentality, all that capacity building and community building. And it really it's been reinforced how important that is. We have to bring people together, build that trust and relationship to even create the space for people to want to care about their occupational health and health hazards. So from the community perspective, it really is incredible to watch how much we all just go back down to that foundational level. And what's the urgent danger? Loss of income. And until you tackle that and feel secure, then it's hard to overcome those challenges. So
yeah, such a very good point. Thanks, Kate. I see Sarah has a hand up, but Jen, over to you for a question.
Yes, there's one in the chat at the moment. Does the NSWP identify good practices to reduce exposure to airborne infectious diseases, including COVID-19, such as improved ventilation and air filtration?
Yeah, we had a module which involved on-site training and a resource and some handouts around respiratory illness and reducing the risks of respiratory illness in the workplace before COVID-19. So some of that translated. And then we did pull in various supports to help build COVID-specific materials during the pandemic, and kind of analyze the different masks and help people understand what did different masks filter and not filter. And how can you improve the ventilation in salons, which was already an issue. So that was, it's nice that it's reinforcing something that we were encouraging before, but really limited on term. Like, just to give you one example, because we're we're the community example happening here. But nail technicians will say, you know, I notice a difference. I don't get a headache the days that we have both doors open and there's airflow, but I don't get to choose whether we open the door or not. And if you open the door in the winter, then the owner's worried about heating costs more. And, you know, these are small businesses. I'm not demonizing owners here whatsoever. But the power and control over those improvements really is a struggle, even when people know what can help make their workplace better. That's a long answer. Jackie, do you have anything to add?
Yes, we actually had the workshops, you know, is talking about the thing is to build the knowledge about, you know, is this very contentious, you know, it's because most nail salons, they don't have a good ventilation system. And we appeal for the many years, you know, is to improve the nail salons, you know, is a ventilation system, it's, but, you know, it's very hard, you know, it's sometimes. And only, you know, sometimes we only can say, you know, it's during the summertime, like Kate said, you know, you can open the door, but the winter time is very hard, yeah, for them. That's it, yeah.
Thanks, Jackie. And oh my gosh, Sarah, you have a hand up, and I thanked Victoria, and this was your brainchild, and it's continuing next week with Sarah on the worker-informed science. So Sarah, over to you. I'm so sorry.
No problem.
Yeah.
And yeah, since it's a small group, thank you for letting me pop in, not via chat. Actually, I'll turn my camera on just to say hi. Hi, everybody. But I just wanted to, I don't even really have very many questions, but I just wanted to echo what Kimberly's already said, to say thank you so much for you both giving this presentation. It's so exciting to see and hear, especially the worker perspective, especially for you, Jackie, to have you here and to hear your full journey of just first even advocating as a worker, but then moving into working on a study and seeing how that process has moved forward. And then to also even just see you on the articles in the different media sources. It must be really wonderful for you and also your coworkers and colleagues to be able to see you in that, reflecting the work and bringing it forward to other people. So I just wanted to thank you both for the work that you're doing, both as worker advocates, but also work at the community health centers for you, Kate, too. It's really wonderful. So yeah, thank you for being here, and looking forward to continuing to follow your work.
Thanks.
Thank you, Sarah, and thanks for the great idea. And yeah, our temporary foreign worker project as well reminds me of some of the of your efforts and how, you know, working with the community health centers and with public health and really, you know, is so necessary to reach and with workers themselves, as Jackie is winning awards to prove, right? That's really how you reach. You know, we scratch our heads. How do you reach? How do you make people care about occupational illness prevention? And, you know, I think Kate's pointing out and Jackie's pointing out, it's relationship building, especially with these, you know, with you know, workers that aren't necessarily organized, and you know, to use the connections that we have in the community. Kevin has a hand up. Thanks.
Yeah, I just want to really thank you both for presenting the great work you're both doing, and also the, you know, the working group with Workplace Health Without Borders is very exciting, and I heard you were sharing that. That's wonderful. And you know, even if you when you have your next meeting, if you want, I can join in, or somebody else. We actually have a Canadian Aerosol Transmission Coalition. It's kind of being coordinated by Alec Farquhar. But you know, if you want to invite somebody from that group to your next meeting through Workplace Health Without Borders, reach out. I know there's been a lot of work with the migrant farm workers. You know, Dorothy Wigmore has been sort of building Corsi Rosenthal boxes, and I just think this kind of area is really kind of ripe for those kind of controls. Yeah, thanks both.
Thanks for the offer. We're heavy on the recruitment phase for that new working group, but I've written you down and we'll remember the offer. Thanks.
More building more building partnerships. That's what we want, for sure.
Absolutely.
Any other questions, Jennifer? Sorry, folks, about my voice today.
There's no other questions in the chat.
All right. Well, if last chance for folks to grab Jackie and Kate while we can, and otherwise we can give you back a few minutes in your day today. Oh, yes, Sarah.
I'm so sorry. I had one more thought.
Please don't. Yeah, don't be sorry. It's great.
The worst to do that right when you're saying we get some extra minutes back. But I also just had the other thought come forward when Kate mentioned the point about as well the struggles with ventilation, especially in the wintertime. And it made me think about just how interesting it is in this process that's so wonderful with being able to work with workers and research partners and community health partners and having everyone at the table all with their own very much needed expertise, because I think even as we keep developing new prevention mechanisms, it just shows how important it is to have worker expertise as its own form of expertise to make sure that the prevention places being put in place in these workplaces also are meeting workers' needs, and we need to hear from workers in order to do that better. So that's really, I just think, a great point and something that we all should be thinking about. So thank you for raising that too.
Yeah, thanks.
Thank you so much. Well, no other questions popped into the window while we were waiting, so you still get, Sarah, we still provided the extra minutes, so not to worry. And thank you again to all of our speakers today. Stay tuned next week to hear more from Sarah. She's spearheading our worker informed session on bridging the science and the worker. We're going to hear about some of the projects at OCAL, and then also we're going to hear a little bit from the firefighters projects from the International Firefighters Association Union, and also Health Canada and IARC, and show how that process floats from regional to local to OCAL work, sometimes to provincial to national to international. So we welcome you back this time next week as well. And then the final week will be showcasing some tools to help make this all easier. So thank you, folks. Take care and have a safe day.